Good morning. I don't have that many slides, which might come in handy because I might be able to catch us up by a few minutes without shortchanging anybody. You know, I've practiced pediatric nephrology for a few decades now, and I finally decided I'm going to force myself to try and understand renal tubular acidosis so I can explain it better to the residents and stuff. And so this meeting was my occasion to put some slides together and come up with as straightforward of an outline and an understanding of RTA as I've been able to do. So the objectives today are to review RTA regarding its etiologies and manifestations, to provide some options regarding diagnosis of RTA, and then briefly talk about treatments. Renal tubular acidosis, as you know, belongs to the family of acidoses, of metabolic acidoses that come with a normal anion gap and that tend to come with some hyperchloremia. Now, there are other metabolic acidoses that are normal anion gap and hyperchloremic, and those are listed here, or at least non-anion gap that don't have to be hyperchloremic. And other than some medication side effects, really the large majority of other non-anion gap metabolic acidoses have something to do with gastrointestinal losses of bicarbonate. And those losses, if you take a piece of the gastrointestinal tract and build somebody who needs it some sort of urinary tract, then obviously those bicarbonate losses can also happen in the urine, but they're still due to a piece of gut that ended up surgically in the urinary tract. I'll also briefly give credit to my colleagues Deepa Chand and Rudy Valentini, who edited a book, a pediatric nephrology textbook, and I took all the tables and figures for this talk from the chapter on RTA in that book. So trying to get this straight is difficult in part because the nomenclature seems to make no sense. If you follow the flow of urine through the tubules, obviously the urine gets to the proximal tubules first and then loops through the loop of Henle and then gets to the distal tubule. Nonetheless, the proximal renal tubular acidosis is called type 2, and the distal types of renal tubular acidosis are called type 1. So it's backwards, the numbers versus the anatomic sequence, which is one of the confusing things that I've been struggling with in renal tubular acidosis. So I apologize for that. I didn't do it. That's how we've used the nomenclature for many, many, many years, and it's probably not going to change anytime soon, and I don't know why we've been doing it that way. That being said, type 1 renal tubular acidosis, also known as distal renal tubular acidosis, has to do with the decreased ability of the distal tubules to secrete acid into the urine. And for reasons that have to do with the interplay of all these different channels and different electrolytes in the urine and in the tubular cells, distal RTA more often than not comes with hypokalemia. Type 2, going backwards all the way up the distal tubule, backwards through the loop of Henle into the proximal tubule that's sitting right below the glomerulus. Nonetheless, it's called type 2. Proximal renal tubular acidosis has to do not with impaired acid secretion, but with the impaired ability of the proximal tubules to reabsorb filtered bicarbonate that has been filtered out of the blood during glomerular filtration and then passes on in the primary urine into the proximal tubules. Filtered bicarbonate is not being reabsorbed properly in proximal RTA. The proximal tubules, as you know, reabsorb all sorts of things when they're working well, and bicarbonate happens to be one of them. Once again, because of all kinds of interplay at the level of the kidneys, the blood work shows either a normal potassium or hypokalemia, whereas the serum chloride tends to be high in proximal renal tubular acidosis or type 2 RTAs. And then to make things even more confusing, where I got this information from for this talk, people who wrote that chapter thought there is a type 3 renal tubular acidosis. I've certainly seen other classifications of RTAs by other people who haven't even propagated that there is such a thing as type 3, which is making this whole thing even more weird because, again, type 1 is distal, type 2 is proximal, should be the other way around if you go with anatomy. There may or may not be a type 3, and then there's type 4. Anyway, for those folks who believe there's type 3 RTA, in a nutshell, it's basically a combination of type 1 and 2, and it's based on dysfunction or deficiency of carbonic anhydrase type 2. Carbonic anhydrase type 2 happens to be involved in both acid secretion in the distal tubules and bicarbonate reabsorption in the proximal tubules. So in somebody who doesn't have a working CA2, there can be a picture that looks like a little bit of both type 1 and type 2 RTA, and then you can convince yourself to call that type 3 RTA. But there's really no consensus that that's a real entity across the nephrology community. Anyway, that brings us to type 4 renal tubular acidosis, and that actually makes sense because the abnormalities in type 4 RTA are, as I like to call it, very distal. They can involve the distal tubules, but then they can also involve structures that are past the distal tubules, meaning the cortical collecting ducts. And all RTAs that are type 4 have something to do, in principle, with aldosterone, either, I guess, adrenal fatigue, if we believe Dr. Russell didn't sound like he believed that really existed, but if we believe those who now go around and talk about adrenal fatigue, or other more established conditions where there is no aldosterone, or where there's plenty of aldosterone, but the receptors in the very distal parts of the nephron, the receptors for aldosterone aren't working, so aldosterone unresponsiveness. And of course, if there's no working aldosterone axis, then one of the typical laboratory findings in type 4 RTA is hyperkalemia. Then the only other and somewhat more simplifying qualification here in terms of definition and classification is that RTAs can either be primary, in which case they're usually due to some sort of mutation of some channel somewhere in the kidneys, or secondary, in which case they often, as you will see, are due obviously to some other condition or some medication. All right, so let's talk a little bit more about almost each one of them except for that ominous type 3. Type 1, as I mentioned, is commonly related to decreased to decreased acid secretion in the distal tubules, and that has something to do with altered HATPase activity, and that then basically prevents the ability to really acidify the urine, meaning to drop the urine pH below 5.5, and that in turn induces kaliuresis, meaning increased urinary potassium, which explains why the serum potassium tends to be low in type 1 distal RTA. Clinical features: persistent vomiting, failure to thrive, some real skeletal abnormalities, rickets in children, osteomalacia, in adults, and that has to do with the fact that the skeleton picks up some of the needed buffering activity, which is nice to do by the bones, but then they get themselves into some trouble. And here's one example for that separation between primary and secondary. Primary causes of type 1 distal RTA are basically channelopathies that are listed here as their genes and a little bit of the phenotype. And then secondary type 1 distal RTA, once again, they're due to some coexisting or part of some syndrome. Sjögren's is listed here, rheumatoid arthritis, and they can also have to do with some drug exposure, ifosfamide, amphotericin B, lithium. So those are some of the examples for secondary type 1 distal RTAs. Type 2, proximal, impaired bicarbonate reabsorption. And again, we talked about this. The obvious end result is that there's a low serum bicarbonate, which actually then means that there isn't as much bicarbonate that's being filtered and that should be reabsorbed by these proximal tubules, which actually makes it possible in proximal RTA, type 2 RTA, to have a very acidic urine. And then the other important consideration in proximal RTA is that the RTA can be not isolated, but can coexist with other signs of proximal tubular dysfunction. And as I mentioned earlier, one of the cardinal roles of proximal tubules is to reabsorb all sorts of things out of the primary filtered urine that's coming out of the glomerulus. And some of the other key molecules that proximal tubules are supposed to reabsorb are glucose and phosphorus, and so that's why proximal RTA can be part of a picture of glucosuria, low serum phosphorus levels because of proximal tubular failure to reabsorb, and also aminoaciduria because amino acids are also supposed to be reabsorbed by proximal tubules, and that combination of findings we call Fanconi syndrome. Once again, there are primary causes of proximal RTA. You can see some genes listed here and some phenotypes here. And there are secondary causes. There's a whole mini differential of Fanconi syndrome, as you can see, and then a whole bunch of proximal tubulopathies such as tyrosinemia and Leigh syndrome, and once again, some drugs can do it as well. So again, a whole list of possible secondary proximal RTAs. We said we're not going to talk about whatever type 3 RTA is because it may not be anything substantial, so we're moving on to type 4. We talked about the fact that it's some sort of aldosterone issue, and therefore it's not surprising that there's typically hyperkalemia. So what kind of aldosterone issues can there be? Either there's adrenal insufficiency and no aldosterone available, or there's plenty of aldosterone available, but the receptors in the kidneys for aldosterone are mutated and unresponsive, in which case it's one of the types of pseudo-hypoaldosteronism. And the laboratory findings, again, are resultant hyperkalemia and an evolution of decreased ammonium and hydrogen secretion in the distal tubule and very distal, the cortical collecting duct. Clinical features do depend on whether there's no aldosterone or plenty of aldosterone, and that can include volume depletion versus overload, hypotension versus hypertension, and so on and so forth. Primary causes, once again, there are some mutations, some listed phenotypes, Additional causes that also include primary causes, adrenal insufficiency, CAH we just heard about, and then again drugs, certain conditions as listed here. One of the things we nephrologists keep in mind is that obstructive uropathy can be associated with aldosterone unresponsiveness and therefore come with a picture of type 4 RTA. Differential parentheses diagnosis, so how do you diagnose RTA, and then how do you figure out what type of RTA you're dealing with? Well, we already mentioned that there's typically a hyperchloremic metabolic acidosis on your blood work. If you get a blood gas, you should see a low pH and a low bicarbonate level and a low PCO2, suggesting there's some attempt to provide respiratory compensation for that metabolic acidosis. And then obviously there should be a normal blood anion gap, and I've listed here what a normal blood anion gap actually is, how you calculate that. The urine can be helpful in several ways. Obviously it's interesting how acid the urine might be, and then if you're worried about Fanconi syndrome, you may see some glucosuria, some tubular proteinuria, and if you look at urinary phosphorus excretion, some hyperphosphaturia. And then it becomes interesting when you want to especially differentiate distal RTA from gastrointestinal bicarbonate losses leading to a metabolic acidosis with a normal anion gap. And the way you do this by using the urine anion gap is obviously the urine needs to have an equal amount of positive charges and negative charges. And for a urine anion gap to be negative, meaning for there to be more chloride than the sum of sodium and potassium, there has to be then some other positively charged anion in the urine, which happens to be ammonium that the distal tubules, if they're working, are secreting, making the urine anion gap not positive and suggesting that any kind of non-anion gap metabolic acidosis with a negative urinary anion gap must have to do with gastrointestinal losses and not with distal RTA. If the urine anion gap is positive, that means there are a little bit of, there's more sodium and potassium in the urine than chloride, then that does suggest that there is not much or no distal tubular acid secretion, and therefore a positive urine anion gap in the setting of normal serum anion gap metabolic acidosis would suggest distal RTA.
2 minutes, please.
Yep. There are some other fancy tests that you can consider or read about. I've never ordered them, so that's why I just listed them as other. And I mentioned that a renal ultrasound might be interesting to look for obstruction if you're worried about type 4 RTA, or if you want to look for nephrocalcinosis or stones, which can be fairly common in type 2 RTA. And then sometimes things are just so confusing and people are just worried that a child isn't growing and the bicarbonate on blood work is 16 and it's a small child, it's hard to get urine and whatnot. Sometimes it may just not be a bad idea to put a child on some buffer and see if that improves the kid's growth. And then you say, oh, maybe we've been treating renal tubular acidosis here. This just summarizes everything I just said in the form of an algorithm. And then treatment is actually very easy. Obviously, they're all acidoses, so you need to use some alkali in type 1, oftentimes with some potassium supplementation because of the common hypokalemia. Proximal RTA, type 2 RTA, typically because of the way these bicarbonate balances or imbalances work themselves out, requires much more alkali than type 1 distal RTA, and also oftentimes benefits from at least part of the alkali supplementation being potassium citrate, so you can also give some potassium. And then, of course, if the proximal RTA is part of Fanconi syndrome, you have to supplement other things like phosphorus as well. And then the treatment of distal of type 4 hyperkalemic RTA depends on the underlying causes. If it's drug-related, obviously you want to stop the drug. If it's related to obstructive uropathy, you want to make sure the urinary tract is drained properly. You want to supplement mineralocorticoids if there's aldosterone deficiency, and then in the pseudohypoaldosteronism types, there is some for type 1. It's very important to restrict dietary potassium and maybe supplement salt, whereas type 2 pseudohypoaldosteronism actually tends to respond to thiazides quite well. And this is just the summary saying that RTAs are a diverse family of normal anion gap metabolic acidoses that can be primary or secondary. It mentions again that an accurate diagnosis is important for all those reasons we talked about, and that treatment largely involves buffer supplementation, but may also require some of these additional measures I mentioned. Thank you.